Assalamu alaikum. This is Dr. Tazeen, your mentor and course director at Study FCPS, and I'm here with another session of Triple P series, which is actually for all FCPS aspirants who are preparing for their exam. And the basic purpose of this series is to prepare you well for your exams, to make you practice the high yield topics, which can be the potential exam tested topics, and then to make you pass this exam with flying colors. So today's topic is about postpartum problems, and among the postpartum problems, basically this is about postpartum hemorrhage, which is the most important and which is an obstetrical emergency and highly tested area in your exam. So you should have clear idea about postpartum hemorrhage, that how you have to grab this topic before going for exam. So if you have not subscribed the YouTube channel of Study Medic, subscribe now and just click on the bell icon so that you can be aware about the Triple P series for the all these FCPS YouTube series, and you can get benefit from there. So let's start today's session and let's see what we have for you to discuss and what we have for you to grab the concepts. Before moving forward to the topic, what I would suggest you guys to that these last few days, keep your passion and dedication alive. That is the key to success, and you have to stay determined. You have to make yourself believe that you are capable of passing this exam, and definitely you will clear this exam in flying colors. So basically, postpartum hemorrhage is loss of blood. Okay, so it is loss of 500 ml blood or more during childbirth, and blood loss which is significant enough to cause hemodynamic instability, and there can be 10% fall in hematocrit from the antenatal levels. So when we say that postpartum hemorrhage, basically this is the loss of blood. At times there can be decompensation, or the woman or the patient, they can be hemodynamically unstable even with less loss of blood, and at times the women, they can stay stable and the major loss is there. So loss of 500 ml blood or more is considered as postpartum hemorrhage, and major or significant postpartum hemorrhage is either there is hemodynamic instability or there is blood loss which is more than 1000 ml. Okay, if there is 10% fall in hematocrit from the antenatal levels, that is also considered as postpartum hemorrhage. It can be minor postpartum hemorrhage where the blood loss is 500 to 1000 ml, and it can be major postpartum hemorrhage when the blood loss is more than 1000, which is further divided into moderate up to 2000 ml and severe postpartum hemorrhage when it is more than 2000 ml. Primary postpartum hemorrhage, exam tested area which is within 24 hours, and secondary postpartum hemorrhage when it is from 24 hours to 12 weeks after delivery. Basically, now talking about major postpartum hemorrhage, we say that major postpartum hemorrhage is when the estimated blood loss is 1000 ml or more, or it has clinical signs of tachycardia, hypotension. Okay, or even if it is the blood loss which is less than 1000 but the clinical signs of shock are there, we consider it as major postpartum hemorrhage. Prophylactic oxytocin can be used routinely in the management of third stage of labor, and they reduce the risk of postpartum hemorrhage up till 60%. And prophylaxis for the women with specific risk factors for the postpartum hemorrhage can also be considered, that we can give those who are delivering vaginally. We can give international units of oxytocin, 10 international units, which is the agent of choice for prophylaxis in the third stage of labor. And the women who are delivering by cesarean section, then the dose is IV. As you know, during cesarean section, you can give IV and the dose is 5 international units. So there are 3 important areas to focus here on this slide. 1000 ml or more is major postpartum hemorrhage, or if there are clinical signs of shock, even if the blood loss is less. Prophylactic oxytocin can be helpful in 60% of the cases in preventing postpartum hemorrhage, and prophylaxis can be given in normal vaginal delivery 10 international units intramuscular, and in cases of cesarean section that can be 5 international units which you can give IV. Then there can be certain reasons that why the patient is having hemorrhage. So first of all, we need to understand that what actually is the cause of hemorrhage after stabilization of the mother, so that we can correct that cause and we can save the mothers. Basically, in 70% of the cases, tone is the major issue. So atonic uterus is among the major causes of postpartum hemorrhage. When it is over distended uterus, there can be certain situations when the uterus can be over distended. This can be multiple pregnancy. If there is history of previous postpartum hemorrhage due to atonic uterus, so in the next pregnancy also patient can go to post hemorrhage. Fetal macrosomia, failed progress of labor, prolonged third stage of labor, prolonged labor, general anesthesia, all these are basically the things which reduces the tone, and they can be cause of postpartum hemorrhage. Then there can be tissue, like 10% of the retained products of conception or abnormal placentation can be cause. 10% of the cases can be traumatic injuries can be there, like tears, lacerations, pelvic hematomas, uterine inversion or ruptured uterus. In the cases of induced or augmented labor, placenta accreta, labor dystocia, operative vaginal deliveries. So all these things should be kept in mind. And then there can be problems with the coagulation, for example, in preeclampsia, if it is intrauterine fetal demise and dead fetus is in the uterus, in cases of severe infection or anticoagulation. So thrombin comprises of 10% of the cases of postpartum hemorrhage, that can be due to prolonged atonic uterus, elevated blood pressure, HELP syndrome, intrauterine fetal demise. So all these can be reasons for postpartum hemorrhage. So what we can do for the prevention of postpartum hemorrhage is to keep the woman's health status optimized, and if there is any anemia, that should be correction of anemia. So immediately after birth we can do uterine massage. Okay, that is not the prophylaxis, but if the patient is going into hemorrhage, then uterine massage or rubbing up the uterus can be helpful. Active management of third stage of labor is significant. So those women who are having risk factors for the development of postpartum hemorrhage, we can do the active management of third stage of labor. So what actually can be given is uterotonics. If the woman is delivered vaginally, we can give 10 international units intramuscular. If it is cesarean delivery, 5 international units intramuscular can be given. Then transaminic acid can be given to the woman, or other uterotonics, ergometrine. Transaminic acid, remember, is not a uterotonic. Ergometrine can be given, but you have to rule out the contraindications for ergometrine, like it is not given in uncontrolled hypertension. Then there comes other uterotonics as well. If we talk about carboprost, before giving carboprost, you also have to keep in mind that you have to rule out the contraindications, as carboprost cannot be given in asthmatic patients. Then there would be early cord clamping, and then controlled cord traction, that can be among the reasons, or among the steps which you can do to prevent the postpartum hemorrhage. So primary postpartum hemorrhage is basically, as we know, that this is 500 ml of blood loss, okay, so which is occurring within 24 hours of the birth of the baby. It can be minor, 500 to 1000 is considered minor, and major is considered more than 1000. Among this, major is moderate or severe, so 1000 to 2000 is moderate, and more than 2000 is severe. In postpartum hemorrhage, one thing which you have to remember is that this is obstetric emergency. So the patient's resuscitation as well as management, they are done side by side. So the basic measures are that we have to we have to achieve IV access. 14 gauge cannula uh, can be secured in cases of minor hemorrhage, while two large gauge cannulas, they are secured in cases of major hemorrhage, and patient can be catheterized so that we can keep a monitoring of intake output as well as empty bladder. It will also help the uterus to contract. In cases of major hemorrhage, resuscitation, it would always be ABC, airway, breathing, and circulation. Then we have to give oxygen, 10 to 15 liters, IV access, as I told, two large gauge cannulas should be there. So position of the patient to be maintained, keep the woman warm, okay, by appropriate measures, and transfuse blood as early as possible. And if the blood is not available, then we can give fluids as well. And for this, one thing is very, very important, that 3.5 liters of warm fluids can be given, okay, so that can be crystalloid and colloid. So 2 liters of crystalloid and 1.5 liter of colloid can be given as required, and the best equipment should be available to achieve the rapid warmed infusion of the fluids. So special blood filters should not be used for non-blood products, as they are slow infusions. Recombinant factor 7A therapy should be based on clinical evaluation and the results of coagulation, and clinical judgment in each situation is very, very important for the patients who are having postpartum hemorrhage. When we talk about the uterotonics, we should be very much aware about the various uterotonics, their contraindications, and the dosage which we have to use. So oxytocin comes, as we discussed in the cesarean section, we can give IV, so the dose would be 5 international units. In normal vaginal deliveries, we can give 10 international units intramuscular, and if we have to run the infusion, that can be 40 international units in 500 ml of normal saline. Symptometrine can be given, okay, so this can be 500 microgram, and symptometrine oxytocin infusion can also be given. For symptometrine or ergometrine, we always have to keep in mind the contraindications, that it cannot be given in uncontrolled hypertension, that is contraindicated. Carboprost is prostaglandin F2 alpha. It can be given intramuscular, 0.25 milligram, and it can be repeated after every 15 minutes up till 8 doses. And we should be very careful if the patient is asthmatic, if there is renal, hepatic, or cardiac disease, that carboprost should not be given. Misoprostol can be given, and then carbetocin is a long-acting oxytocin derivative. IV bolus injection can be given 100 microgram over 1 minute. It is given as a single dose, and it is avoided in vascular disease, especially coronary artery disease. When we talk about the anesthesia in patients who are at the risk of postpartum hemorrhage or who are having postpartum hemorrhage, that is basically in close liaison with the anesthetist. If cardiovascular stability has been achieved, then and the patient remains stable, then further bleeding is unlikely, and there is we can go for spinal or epidural analgesia. When there is ongoing bleeding or cardiovascular stability is compromised, then general anesthesia is preferred, and a rapid sequence induction with pre-oxygenation, required pressure, endotracheal intubation should be used to reduce the risk of aspiration in immediate postpartum patients. And all emergency equipments, including difficult intubation, invasive monitoring, anesthetic medications, cardiac supports, and inotropes, they should be checked and they should be readily available when we are managing a case of postpartum hemorrhage. So whenever there is a case of postpartum hemorrhage, always remember that this is obstetric emergency. Okay, so call for help would be there, and after that there would be bimanual uterine compression, which we call as rubbing up the uterus. Okay, so this is done to stimulate the contractility of the uterus. Then bladder should be emptied, so Foley's catheter is passed and it is left in place. Then we can give the uterotonics. So syntocinon 5 international units by slow IV injection can be given, and the dose can be repeated. Again, ergometrine 0.5 milligram by slow IV intramuscular injection can be a next step if the patient is not responding to syntocinon. But always remember that it is contraindicated in patients with hypertension. So if it is mentioned in the scenario that patient is hypertensive, so our next step would be omitting the ergometrine. Okay, so we will omit ergometrine and we will move forward to the syntocinon infusion instead of giving ergometrine to the patient, as it is contraindicated. After ergometrine, if there are no contraindications or no allergies and the patient is still not responding to ergometrine, the next step could be syntocinon infusion, 40 international units in 500 ml normal saline, okay, at 125 ml per hour. Unless fluid restriction is necessary, then it can be 80 ml per hour. If the patient still is not responding to syntocinon, then next step would be carboprost 0.25 milligram by intramuscular injection. It can be repeated after 15 minutes up till maximum doses of 8 doses. And again, if in the scenario it is given that the patient is asthmatic, then we have to be very cautious that carboprost won't be given to that patient. And next step would be, it can be misoprostol. Okay, so direct intramyometrial injection of carboprost 0.5 milligram can also be given, but again, remember the contraindication, and misoprostol would be given to these patients. So basically in the exam scenarios, it is always a stepwise approach, that some management of the patient has been already done, and then it is asked that what would be our next step. Or they are giving us an obstetrical emergency and they want to see that how the teamwork, or how we know that we have to manage this patient. So resuscitation and management would be simultaneous. And before that, as this is obstetric emergency, a teamwork is needed, so call for help. Senior midwife, obstetrician, anesthetist should be there. We should alert the hematologist. Blood bank should be alerted, and blood transfusion laboratory should be intimated. Resuscitation would be airway, breathing and circulation, oxygen at 10 to 15 liters. Then fluid balance, we can give 3.5 liter of fluid, we can give until blood is available. And among these, 2 liter would be crystalloid and 1.5 liter would be colloid. This is again an important exam tested area. Blood transfusion can be done of Rh negative or group specific blood, and blood products can also be transfused as per need of the patient, including fresh frozen plasma, platelets, cryoprecipitate, factor 7A, and we have to keep the patient warm. So then there comes the monitoring and investigations of the patient. So in the monitoring, 14 gauge cannula, 2 large bore cannulas are passed in major hemorrhage, full blood count, coagulation, urea electrolytes, liver function tests, cross match 4 units of blood, fresh frozen plasma and platelets, and cryoprecipitate should be available. ECG oximeter should be attached, for patient should be catheterized. Hemoglobin bedside testing should be available. Blood products should be available, and blood bank, as we already mentioned, that blood bank should be informed. And we can consider central and arterial lines for the monitoring. And basically in postpartum hemorrhage, the estimation is always that is under measured, we can say. So all the swabs and estimated blood loss, it should be accurately measured so it can be replaced. Medical management, again, as we discussed, it will start up with rubbing up the uterus, then would be catheterization, that we have to empty the bladder. Then there comes first uterotonic oxytocin, 5 international units IV in cesarean and 10 international units intramuscular in cases of vaginal deliveries. Next step would be, next uterotonic would be ergometrine 0.5 milligram, but contraindicated in hypertension. Then next would be carboprost 0.25 milligram intramuscular, which can be given up till 8 doses, and each dose which is spaced by 15 minutes, that we can repeat the dose after 15 minutes. Carboprost intramyometrial 0.5 milligram can also be given. Then there comes misoprostol, which can be given, and transaminic acid can also be considered 1 gram IV. So this is basically, up till now, this is the medical management of the patient, that we are doing the medical management. If the patient is not responding to medical management, then we can move forward for the surgical management. Among the surgical management, the first step would be definitely balloon tamponade. If the patient is not responding to the medical management, and we feel that the cause of hemorrhage is uterine atony, and then there would be further management, that compression suture can be there, stepwise devascularization can be there. We have to make sure that if it is not controlled, then we can either involve interventional radiology if it is available, or the next step can be hysterectomy. And it is always said that early recourse to hysterectomy in cases of postpartum hemorrhage to save the mothers is always important than late recourse to hysterectomy. So this is always important, and we should keep all these things in mind when we are monitoring the patient. So as we discussed, the fluids and fluid replacement is very, very important in the cases of postpartum hemorrhage. So crystalloids are 2 liters and colloid are 1.5 liters. Then blood can be given, which can be O negative, RH negative, K negative. Red cells can be given until group specific blood is available. Fresh frozen plasma can be its administration, it can be guided by hemostatic testing and whether the hemorrhage is continuing. So PT and APTT, if they are prolonged and hemorrhage is ongoing, we can administer fresh frozen plasma 12 to 15 ml per kg. And if hemorrhage continues after 4 units of RBCs and hemostatic tests are unavailable, then we can also administer 4 units of fresh frozen plasma. So there can be two statements in the exam, that one is that if the coagulation is deranged, PT-APTT is given, they are deranged. So that is again an indication that we can give fresh frozen plasma. Or there can be that 4 units of blood has been transfused, the bleeding is ongoing, bleeding has not been controlled, and hemostatic tests are not available. So then it is an indication that we can administer 4 units of fresh frozen plasma. One pool of platelets can be administered if hemorrhage is ongoing and platelet count is less than 75,000, and cryoprecipitate is administered. We can administer 2 pools of cryoprecipitate if the hemorrhage is ongoing and the fibrinogen levels are less than 2 grams per liter. So this is very important exam tested area, that when we have to give fresh frozen plasma, when the PT-APTT coagulation is deranged or 4 units have been transfused, hemostatic tests are not available, and bleeding is ongoing. And when we can give platelet concentrates, that is 1 pool of platelets if hemorrhage is ongoing and platelets are less than 75,000. And then there comes cryoprecipitate. That cryoprecipitate we have to give when the fibrinogen levels are less than 2. Urgent investigations, as we discussed, that it is very, very important to achieve the IV access. Urgent venopuncture can also be done. 20 ml of blood is withdrawn for group and screen CBC, coagulation profile, fibrinogen, liver function tests. So all these tests are carried out. And then we have to monitor pulse oximetry, respiratory rate, blood pressure recording every 15 minutes, and patient should be transferred to the intensive care unit once the bleeding is controlled, and the monitoring at high dependency unit in the labor room if it is appropriate. Recording of parameters on a modified early obstetric warning score is done, and the aim of management is to keep hemoglobin levels greater than 8 grams per deciliter, platelet count more than 75,000, PT less than 1.5 times of normal, APTT less than 1.5 times of normal, and fibrinogen should be greater than 2 grams per liter, which is actually the aim of management, that these are the targets which we have to achieve, which can ensure that the patient would stay stable. So rubbing up the uterus, uterine packing can also be done as other interventions, and balloon tamponade. Always remember that balloon tamponade is actually the first surgical step in the cases of postpartum hemorrhage, followed by there can be uterine compression suture, which can be B-Lynch or modified B-Lynch. Here also remember one thing, that if they are giving us a scenario in the exam tested areas, patient has delivered by vaginal birth, we can easily go for balloon tamponade if she is having hemorrhage and not responding to medical management. But if you are doing a cesarean section and the uterus is atonic, then it is advisable to go for brace suture. As the patient is open, you can apply compression suture instead of doing the balloon tamponade. So that can be your suitable option, as you have to choose the most suitable answer. So that can be uterine compression suture in those statements. Uterine artery ligation, bilateral can ligate. Okay, you can also ligate uterovarian. Okay, internal iliac ligation can also be done. If there is any rupture or tears or lacerations are there, they should be repaired. And if the bleeding is not responding to anything, then as a last resort, hysterectomy is done. And when there is major hemorrhage, then subtotal hysterectomy can be done, as it is associated with less bleeding. There can be less time, it can be less time consuming. But again, you have to in the post-operative period, you have to tell the patient that she may need to continue her pap smears. She can have blood loss like menses, and these can be the things which can be there with the subtotal hysterectomy. And if in the future some cervical pathology is there, then she may need another surgery. But as this is an emergency, so subtotal hysterectomy can be done. In the post-operative period, patient should be monitored, vigilant, intake output charting, vital record, venous thromboembolism, risk assessment, good hydration, good pain relief. And if the need arises, anticoagulants can also be given to the patient. Once patient is stable, she can be shifted to routine ward. And once she is up and above, she can be discharged home. So this was all about postpartum hemorrhage, that how you have to take up the questions from postpartum hemorrhage in the exam. I hope this will help you in your exam. And we at Study Medic wish you all the very best for your upcoming FCPS OBG exams. So again, if you have not subscribed the YouTube channel of Study Medic, subscribe now, join all the free groups of Study FCPS and enjoy learning. Have a great day.